Welcome to First Friday Fertility. I'm Dr. Preston Parry. Today we're going to be talking about how IVF has evolved in the past year, and we're going to really be zooming in on all kinds of things from, what we think about PGT and what we think about ERA and all kinds of other issues that are a bit more nuanced. And so I'm going to be talking about sort of state of the art, what we think is real. And remember, all of the stuff for medicine continues to evolve. So everything I'm going to say is how I see the world to the best of my knowledge right now. And I think there will be people who have different opinions, and there are people where this is things that I say are generally true, but there may be exceptions. So as with anything, this is general medical information. Of course, talk with a clinician about whether knowledge has evolved or your circumstances might have this apply differently. In terms of the top questions, remember IVF. What is IVF? IVF is in vitro fertilization, and it's where you take sperm and egg from outside the body, put them together in the lab, have the embryo grow, and then put an embryo back in the uterus. And that's really the single most powerful way of getting people pregnant who need that extra level of support. Obviously, if a person could get pregnant spontaneously, most of the time there isn't a reason for IVF, with rare exceptions, such as avoiding serious and lethal genetic defects for things. So that's one of the top things for IVF. And we'll get into the alphabet soup of ICSI and PGTA and all those other types of things. One thing people say, well, why do it? Well, again, if you can get pregnant spontaneously, there's no need for advanced surgery. So you don't have a person who's perfectly healthy walking around and then all of a sudden decide to do open heart surgery for them. It's the people who need open heart surgery to protect them. So similarly, IVF is done for people who have more advanced needs. For intrauterine insemination, why do IVF instead of IUI? And again, if you can do things low cost, low tech, and have them work, go for it. But you look at Louise Brown, for instance, world's first IVF baby born July 25th, 1978. Her mom's tubes were obliterated, and if sperm and egg can't meet, kind of hard to get pregnant. Or you're very likely to get an ectopic or tubal pregnancy if the tubes are damaged. And you can see this for people where there's very low sperm counts, where they're unlikely to meet an egg. You can see this for people where they've been trying all kinds of alternative therapies. Not only the tubes are damaged, but also the eggs are older and have chromosomal abnormalities. So you have to identify which ones have chromosomal abnormalities. You have people with lethal conditions, that basically they have a condition that would lead to a heart defect, that in turn the baby would be carried till term and then pretty much live for a few days and then not make it. And these are just devastating and tragic. And if there are things we can do to help conceptions be ones that are likely to result in a healthy child, those are good things. So, obviously we want the right thing for the right person. Now, the next thing people are always saying is, well, how well does it work? And the answer that's always right in medicine is it depends. First of all, some places with really high pregnancy rates, well, they're doing it because they're people with, they're not so much infertile. And if you're having a really low threshold for IVF and you're getting people who pregnant with IVF who could have gotten pregnant in other ways, then your success rate is going to be higher, but that's not necessarily saying you're a good lab. It's just saying that you, were taking fertile people and helping them continue that course. I think we're very proud of our pregnancy rates, and I believe we are above the national average comfortably. But despite having some people with meaningful health conditions, and again, I've had a other embryologist come down, see our lab, and say, man, if you were in Colorado, if you were in the Seattle, your pregnancy rates would be even 10% higher, because we have some people with some extra weight and health conditions and fibroids and other issues where the uterus is very complicated. While we talk about fertility as sperm, eggs, tubes, and uterus, and obviously the tubes matter a little bit less for IVF if you're bypassing them, with rare exception. One of the questions I get, do you have to have tubes to do IVF? No, they can be tied, they can be removed. You can even have a hysterectomy, get the eggs from one woman and then have another carry it. So you don't really have to have the tubes, but you want to make sure there's not a dilated damaged tube called the hydrosalpinx, and that can drop success rates by 2/3. One of the things, I just came back from the hardest conference, phenomenal conference in Rome, and it was for hysteroscopy, ART for IVF, and US for ultrasound. And basically we're concluding most of the voodoo that's thrown out there, all the Geritol, Robitussin, pineapple core, salty McDonald's French fries, not really relevant. What really drives fertility, we say, probably, and again, people can debate these numbers, but roughly 60% is the embryo, and 30% is the uterus, and then 10% these rare things that usually are more prominent, but for the most part, most of whether an embryo takes is, it's the passenger and it's the vehicle. It's the resident and the home. Is the home structurally sound? Is the resident, going to be a healthy tenant? And there is no amount of making for a perfect uterus that will offset a chromosomally abnormal embryo. And there's no amount of a perfect embryo that can offset a horrific uterus with fibroids and scarring and obliteration. The perfect embryo can't offset hysterectomy. So similarly, we have to give respect to both. And I believe it was in my First Friday Live where I talked about the hardest conference a little bit. So if you want to know more on uterine anomalies and emerging thinking on the uterus, definitely check that video out. For, once you've sort of done things, you want to look again, sperm, eggs, and the uterus for things. For the sperm and eggs, I think everyone says, oh, if I get the perfect egg and I have a great lifestyle, that will make all the difference. No. If you have a 70-year-old male, there is a difference in the pregnancy rates from a 30-year-old male for using donor egg. And so obviously sperm quality matters. And in fact, when you see lower implantation rates with embryos that have used donor egg, a lot of the time it relates to the advanced paternal age, not just the fact that you got the donor egg. So that matters. And similarly, lifestyle, smoking, alcohol consumption, these tend to fragment sperm as well as fragment the eggs. So you also want good eggs. Be well. One of the things that we are looking at as we looked to, there's a great paper by Pertea, which was suggesting 92% of people with a chromosomally normal embryo were pregnant within 3 transfers. For things. I think people think that may be overestimating things, and the reason is there are a lot of people who don't have a normal uterus, and there's debate as to what constitutes a truly normal embryo. So there can be some selection pressures, but the more normal the embryo, the more normal the uterus, the higher the chances that things will take. Remember, when you do IVF, everyone thinks, oh, I got 20 eggs, that gives me 20 embryos. No. There are a lot of people who need extra embryos, not only for additional children, but because not every egg that you get is mature or receptive to sperm. Not every egg that should be receptive to sperm actually fertilizes. Not every egg that fertilizes develops into a mature embryo. And not every embryo will implant or attach. And some of those that do implant and attach actually can miscarry. And so when you look at people and ask, well, what am I going to get for what we do? And again, chemotherapy history, smoking history, like a lot of things for toxins or, that may affect quality, that may shift your numbers. But generally, you see about 30 out of every 4 eggs, you'll get 1 embryo. 35, it'll take 5 eggs. So 30, it's roughly 4 eggs for an embryo with a 40% chance. 35, it's about 5 eggs for an embryo with a 30% chance, and 60 is about, 40, yeah, I'm not doing any IVF at 60. 40, you're getting about 6 eggs for an embryo with a 20% chance. The older a woman is, the more eggs it takes to get a slightly lower quality embryo, and other factors can influence that, but that's ballpark yield. And so you have to just say, everyone always talks, oh, this is our clinic's pregnancy rate. But the question isn't what the clinic's pregnancy rate is. It's what the pregnancy rate is for you as an individual. Because you may have different circumstances that make it better or worse. For instance, you could be 35 and everyone says, oh, I'm worried I'm 35. Well, if you've had 3 kids before and a tubal ligation, your pregnancy rates is going to be a lot better than the person who is 35 and sperm and egg have met for 8 years and they were bad quality, or all these other factors that go into it. So you really have to individualize the estimates for things as much as you can. The next thing we get a lot of questions on is sort of what does it cost? And I think, that's evolving. I think healthcare, there's inflation like in everything in our society. And I think there's 3 approaches. One is the maximalist. Let's do everything possible. We'll throw cash at the wall to see what sticks, but maximum pregnancy rates. And there's some people who have money to burn, and that's right for them. I don't see a lot of those people. I do see a bit for people where they're more on the minimalist. They want to say, look, I have almost no money to spend, and I just want to have a shot at things through IVF, or again, other approaches. And there are many things you can explore for people before IVF, right thing for the right person. But at the same time, often a lot of those people are going to programs where there's really very little support, suboptimal communication. They have to do a lot of homework, and there's more propensity to get things wrong. And then I've also seen a lot of those cases where you're told you have a low cost, and then there are all these add-ons and people get nickeled and dimed to death, or they get into these fringe therapies, which is how people make the money. And they're trying to have these low costs as loss leaders, but the true cost ends up being much more. And so there's a degree you've got to be a little buyer beware on those things. We tend to be value. I'm married to an economist. My wife says dollars spent per pregnancy achieved. I try to look at financial efficiency. And I always say to people, look, if you have a different plan, different way of wanting to explore things, I'm open-minded. But my default tends to be, how are you financially efficient to maximize pregnancy and find a good balance there? And again, each person has their own art, but that's something we're pretty passionate about for things. It is another thing that always needs to be addressed is just that IVF is an emotional roller coaster. Again, you will have all these hormones you're pumped through and it's difficult, and you care so much about the outcome because it is identity. I think many people not going through the journey don't realize how much of yourself is put into this, which is saying, who will my family be? Who will we be? And all the variability and all the hopes, and then it doesn't happen until it happens. And again, when people want to get pregnant deeply and can't, you can see a 50% rate of major depression, 50% increase in divorce rates. So the ability to build a family effectively, it doesn't just expand it. It actually prevents you from eroding the relationships that are already there. So good support matters for things. So I definitely think you need people, and don't go it alone. Get support for things. Top things I get, I'm going through it. First, how big are the needles? The needles for much of the pre-transfer stuff, these are sort of on the insulin syringe side, and they're fairly small. Again, I'm saying that as a person not getting it, so I have a lot of respect, and I'm not an acupuncture style guy. I don't want to jab people full of needles. But the compounds that are used to cause the eggs to grow, the follistim, the menopure, there are multiple gonoleth, there are multiple compounds out there. They're proteins. And if you take them like a pill, you'll digest them like a steak. And these are expensive meds, so that's why you give yourself shots for them. for things. Again, gonadotropins really tend to be on the smaller, the Lupron a little bit on the smaller. The big needle that everyone complains about is for the progesterone. That is a harpoon. I'm not mincing words. It is a big needle. But again, the best study that's been done, it was 2021 for Divine, published in Fertility and Sterility, showed that you had half the miscarriage rate by doing the injectable progesterone as suppositories. So for all the effort people put in, most people say, I just want to be pregnant, let's go with the shot. But there's some people who just can't take the shot and have done suppositories, and I've seen pregnancies with that. You just have to worry a little more for miscarriage. For the next thing people are saying, well, you're going through ultrasound monitoring, and we have a video separate for that, the details of the process. But again, you're getting the eggs lined up, you get them to grow, you then figure out when you give the HCG to get them out, and then ultimately worry about getting the embryo transfer to put things back in. For anesthesia, for us, we use propofol, so people are very comfortable. It's a twilight sleep for things. Again, I think people are very worried about how much they will feel or be awake during the procedure, and for us, people don't really remember it. They are resting very comfortably. I do think, though, people are sore. Again, this is more for the other video, but if you get 20, 25 eggs in a month, your ovaries are going to be 8-10 times their normal size. And, I tell people this is indelicate. I will repeat it. You'll hear me a lot on this. My testicles were 10 times their normal size. You'd be man-spreading and uncomfortable for things. Similarly, the ovaries are incredibly big and they press in on the rectum, and not only are they sore from a bruise, everywhere you get an egg, you get a bruise, but then also they press in on the rectum and everyone feels constipated and they feel the need for Metamucil and Colace and all those things. And I also say this, it's indelicate, I'll repeat it. You're not going to poop out your ovaries. And if you haven't had anything in, then there's nothing going out. And people say, well, if I haven't had a bowel movement in a while and I'm feeling all this pressure, it must be constipation. No, it just feels like that because that's how the body interprets the rectum having pressure from the ovaries. But anyway, you get propofol, and so I think people are most sore that day, a little bit more maybe the next day, and then the second day they improve. Then 3 through 6, I think it gets a little worse. That gets a little more bloating relative to the immediate surgical discomfort. Most of the people for who have discomfort through IVF, I usually see it falling into 3 categories. 1, they got a lot of eggs. More eggs you get, more you're bloated. Second, people bruise or bleed easily. And if you bruise or bleed easily, you'll bruise or bleed more into your ovaries. That's why we talk about not taking baby aspirin before retrieval, because you'll just be much more sore. And if you need extra eggs, go up on the Gonal-F or Follistim or Menopur. Be aggressive in the stimulation. Don't do the baby aspirin, which will hurt afterwards. And then 3, people with different degrees of stoicism. This is not a judgment. Some people take pain very well and others not so much. That's, again, not judgment. It simply is for where people's equilibrium are. And if you have trouble with discomfort, then you're more likely to have trouble with discomfort post-IVF as a general rule. Also, if people have endometriosis, the pelvis is inflamed and they tend to be more naturally sore, they're more likely to be uncomfortable after IVF. By the way, when getting propofol for anesthesia for things, one of the reasons for doing it is because you don't want people moving around. You are 1 millimeter away from the external iliac, which is 10% of your blood moving through your body in a given minute. You don't want someone writhing and a needle gets in that. That's an incredibly rare risk. I've been doing this 20 years. I've never had a patient have the needle get into the external iliac for things, but that can be, I know of one person who had it happen to him, and it was 25 units blood transfusion and 6 hours vascular surgery to save the leg. It's really, really serious. So I would say, you want people comfortable so they aren't moving to reduce the degree of risk for things. Very important. Also important is remember nothing to eat or drink after midnight the night before or 8 hours prior to your retrieval, because you don't want to aspirate as Jimi Hendrix did. Now again, he was on barbiturates, but you we want to protect you, and definitely don't take food just before a procedure. And if there is anything, you need it directly cleared with anesthesia beforehand. Next thing people are saying is, by the way, after the retrieval, what are the things for the transfer? Day 3, day 5, day 6, day 7, fresh versus frozen. So first of all, for day 3 versus day 5, the embryonic stage versus the blastocyst stage. Honestly, I used to be pro day 3. As I've looked at the data, that's not when the embryo reaches the uterus and the ovaries are still a little bit inflamed. Much more of a day 5 believer, and I can't remember the last time I did day 3. That's a whole story in itself for another thing, but most people are doing day 5 transfers. Day 5, if you're 50% on a day 5 embryo, you might be 40% for a day 6 and a 30% for a day 7. Longer you go, it's sort of like the morphology, where the lower the grade, it's a little bit lower for implantation rates. Similarly, the longer you go, there's a little bit of a hit. But I've seen a lot of cute babies from day 7 transfers, so you don't want to abandon or give up on those embryos. You want to give them a fair shot for things. Fresh versus frozen, really, most people are moving towards frozen for things. Because here's the thing. If you have a ton of eggs, you're hyperstimulated and the ovaries just need to cool down, so you don't want to do a fresh transfer often with that. And if you have fewer eggs, often that relates to ovarian reserve issues, which can relate to chromosomal abnormalities, and you want to do PGT to make sure there aren't chromosomal abnormalities. I'll come back to PGT, but most people are just going to frozen embryo transfers these days. And people talk about a 1% difference between fresh and frozen for outcomes. But again, that's also for people without hyperstimulation to a degree, and everyone gets a little bit, or most people do, from things. So we're really moving mostly away from frozen. If you have 5 embryos, and 4 were 50% and 1 was 51%, that's not very much different from 5 being 50%, particularly if that 51% was actually a 45 because of hyperstimulation. So again, talk to your clinician when addressing these things. How many cycles do you transfer? Everyone's saying, I want to be pregnant as quickly as possible. Most people don't realize that there's often a cool down range. Now again, if you're fewer than 10 eggs, fresh transfer, very easy. 10 to 20, many people are saying, let's do a fresh transfer or wait a month. There's a lot of flexibility. As you get to 20 to 30 eggs, you often need about 2 to 3 months to cool down. And above 30 eggs, you often want the 3 months. Now, people will debate this, but the thing is, if you have a lot of corpora lutea, which is where you ovulated from, and they have a lot of hormones, going out, that can throw off the window for the lining for when things want to attach. And you don't want to do a transfer and said, if I'd only been a little more patient, that would have been what made or broke me for whether that embryo took. And that's only for the first transfer. Now again, if you do a transfer and it doesn't take, usually the following month you can go straight into another transfer, providing it hasn't gotten to 10 weeks and then there's a miscarriage, which is rare, for things. Because then you might have some residual placenta, may need a little bit more to clear out. But again, most people, sort of in that, 10 eggs, 20 eggs, 30 eggs sort of rule for 1, 2, 3 months for how long you wait for things. When to test? Testing, oh my gosh, it is so hard. Everyone wants to be pregnant already, and they want to know for sure, and so they test early. Well, especially if you're doing a fresh transfer, you'll still have the HCG in your system and you get this faint line and you're saying, is it real? Is it the shot wearing off? Is it a miscarriage? Drive yourself crazy. So when you do the retrieval, that's sort of the day of ovulation by definition. And usually you say the embryo you froze on a day 5, even if it's a 6 or 7. So if day 14 is the mid-cycle day of ovulation, so to speak, for retrieval, you add 5 more days. So whenever you do a transfer, you're roughly day 19. You could have had the embryos frozen 3 years ago. You're not 3 years pregnant at the transfer. So you call it day 19. And that's why people wait a week and a half to do the pregnancy test, because that'll be day 28, 29, 30. And that's the time of the missed period. And you usually are looking for HCGs in the 60 to 150, and it depends on your assay and things like that for things. And sometimes if you see the numbers really high, by the way, that can be more of a sign of twins. So you definitely watch for that. People will read about molar pregnancy as a sign. I don't think I've ever had a molar pregnancy with IVF, to my recollection. So it's pretty rare for things. So don't overanalyze, but yes, you do look for higher HCG, sometimes reflecting multiples. By the way, normal is one embryo back at a time, particularly for PGT, but you have to have the right thing for the right person. So I'd say maybe 1 in 5 embryo transfers, I'll do a second embryo transfer. I can't remember the last time a third. A fourth would probably be over 20 years ago. The data or the field has just evolved so much since then that's really, really rare and outside the usual standard of care. Not that you can't make it an exception or vindications, but I would say really 1, 2 tops is sort of the norm that you encourage without extensive counseling before. But again, keep yourself distracted waiting for the HCG test. And you don't have to be on bed rest. That often will give you a blood clot without helping things. There's very good data. Some people say even after the transfer, you can immediately get up and resume normal activities. We still tend to keep to a 10-minute window, but I think if you really study the data, that there's actually some flexibility, that there's no difference between immediate and even lying down for 2 hours or 2 days. So don't feel obligated. By the way, some people give Valium to reduce the risk of ectopic. If the uterus can migrate from the tube to the uterus, it can migrate from the uterus to the tube. I think I said that reverse. Tube to uterus, uterus to tube. And the uterine, relaxing the uterus, I think, is going to be an emerging field. How does the uterus contract and when? That's something we have to do. Now, ICSI, a lot of people are doing ICSI all. I think there's a good case to say, hey, you don't have to do it for everyone to put the sperm in the egg. 3 things we really see for ICSI, putting the sperm in the egg. So one, you have a little bit of risk of breaking it, although that's pretty rare. I think we've gotten pretty good at avoiding that for things. The second is can sometimes add costs. In our case, we bundled it so you're not having added costs. And there's some rare imprinting disorders. People often talk about some of these in the 1 in 10,000, 1 in 100,000. They're rare. So there's a little bit more to it, but I've seen in the South high rates of complete fertilization failure, which doesn't make sense to me. It's supposed to be 1%, and I've seen it unexplained, sometimes even getting to 10%. I can't explain that, but that's sort of where, the sort of people started moving a little bit away from swim up and conventional fertilization to ICSI all. But again, there's some flexibility on this. But again, I think the thing people want to know, your wife, your shoes, or our shoes, what would you do? I'm just in the ICSI all camp, recognizing people can debate this and there's data supporting other approaches. For IVM, in vitro maturation, that's where I would say that's something that people hear about to decrease hyperstimulation. You take immature eggs and then culture them in the lab before putting the sperm in them. I think there are very few programs that do it regularly and do it well. Peter Ruzelak, by the way, Marin Fertility is really good at it out in California. But I would say that one thing that people don't understand for IVM is they think, oh, it means no medication. Actually, no, the best success rates, from my understanding, seem to come from using the same stimulatory medications you would for IVF. You're just getting things at an earlier point. And so if there can be, you can argue whether it's a lower fertility or there's a degree of bias for it. I would say you have to have some pretty good counseling to go down this route. Usually it's for people with such bad PCOS that you just can't retrieve them the normal way for in vitro, and you have to explore in vitro maturation. Some would say just do ovarian drilling and then they can get back to a normal level for stimulation, but that's an art. Assisted hatching, by the way, also a controversial topic. Some of the best data I've seen really said to now first, you can argue 35 versus 37, but as you start getting into that range, there's more benefit. And also people talk about it for a hardened zona pellucida, which is the shell around developing embryo and an egg. Basically you have to drill in, and that helps with attachment. There's a lot of data saying that it doesn't help, particularly if younger women. However, the thing is, if you're doing PGT, which again, increasingly more and more cycles in the USRR, where you're biopsying the embryo, you have to do the assisted hatching anyway to get to those placental cells to understand the genetics of the embryo. And so really a lot of it, because you don't want doing a biopsy and then also the sperm ends up getting fused. There are all kinds of little things that can go into it. Most people are assisted hatching at this point. Also for frozen to help it sort of perk up and come out. There's a long list. I would say if you have concerns about that, talk to your clinician. But assisted hatching seems to be bundled in to a lot of what's already being done these days. Now PGT, one of the hardest areas of controversy these days, and where we're seeing some of the greatest evolution. By the way, PGT, it used to be called PGD for pre-implantation genetic diagnosis. Now it's pre-implantation genetic testing. 3 different types. A, M, SR. PGTA, aneuploidy, means chromosomal abnormalities. You know what? You want to understand whether the DNA is normal before putting an embryo back to decrease miscarriage. If an embryo is fully abnormal, there's a very, very low chance it would actually take. PGTM is looking for monogenic disease, cystic fibrosis, Tay-Sachs, thalassemia, spinal muscular atrophy. Genes that often you want to understand for where people are. And then PGT-SR4, it relates to reciprocal translocation. It's these fancy DNA arrangements, and those are rare but relevant and can be a source of non-implantation and miscarriage. So anyway, for PGT, some people are again saying, I just want to know the DNA. Absolutely a good thing to do for many women, and again, I lean towards it for my wife. The controversy was there was a trial called the STAR trial where they didn't see really a benefit for those with PGT versus not. And if it's adding cost, and an embryo is what it is, why would you do PGT? I think that there's a lot of debate. I would say the older you are, the more benefit there is for PGT. The other thing is the benefit from PGT isn't entirely from just determining, whether an embryo is chromosomally abnormal or not. That seems controversial. It's not for saying who will get pregnant, to rephrase. The embryo is what it is. You put it back, it'll either take or not, but rather there's some other things. So first, if you're putting back abnormal embryos, more likely to have miscarriage. Second, if you are choosing the healthy embryos, that accelerates the time to conception. If you have put embryos back and then they don't take or they miscarry, and that slows you down. It also adds cost for many people, because if you're paying for transfers for an embryo that never had a shot, that's wasting your time and your money. Some people also would put back an embryo with Down syndrome, others would not. But that's something that's information that's gathered with PGT. I think also knowing what you have in reserve. If you have 5 normal embryos in reserve, that gives you a sense of what that future family is, and is very different from, hey, you're pregnant right now, but all 5 embryos that were frozen are actually chromosomally abnormal. That's very important to figure out on the front end. So I think there's a degree of control, even peace of mind. This is another advantage to PGT. Again, it's not perfect. I always say it's like looking at a book. It'll tell you a chapter is missing, a page, paragraph. Can't tell you a sentence, word, or letter is missing, because it only has a degree of resolution to the base pairs for things. But knowing, when an embryo doesn't take, people say, was it my lifestyle? Was it my stress? Was it my sleep patterns? Was it my diet? And if you knew that the embryo was chromosomally abnormal, and therefore if it wouldn't have taken anyway, and you figured that out on the front end, that takes away some of those pressures and that self-blame and guilt and doubt. So it's very important to understand that. Now, beyond the limitations to the accuracy of PGTA from sample size. You can only, again, people talk whether it's 5 megabase or 10 megabase, which is 5,000 base pairs, or 10,000 or even 4,000. Again, those numbers are for debate. But the thing is, beyond that, there are limits to what it can read. It can't tell you, again, that a single letter mistake in the genetic code is there. These are frame shift mutations, point mutations, things like that. This often can't be picked up with modern PGT unless you do whole genome sequencing. And then you're getting a lot of information and we don't entirely know what to make of it. So that's even its own area. The other limitation to PGT is the mosaicism of the embryo. We think of it as a single genetic line. It isn't always. Now, I think I've seen a few rare cases where there's a meaningful gap between what was biopsied in the placenta and the actual embryo being genetically different, but that can happen. I think we need to move how we think about PGT, not from this black and white, normal, abnormal, but to a continuum. And this is where you get normal and aneuploid for abnormal on the ends of the spectrum, and then in between are your low-level mosaic and high-level mosaic. And so normal, depending on the lab you use, is there can be even 20% errors, or 20% where the embryo doesn't look okay, and that just may reflect limitations to testing. You know, a little dust of DNA got in there and it amplified it, making it look like there was something when there was not. It failed to amplify because one strand of DNA was degraded. Remember, you're only taking 6, 8, 10 cells. And so there are, may be limits to getting too much or too little, just as that's all modern medicine can do. And so that's why some people use a 20 or 30% cutoff for things. Then, if you're above that 20 or 30% cutoff and you're up to 50%, this is called the low-level mosaic, where it's not above 50%, but there is some error that, that's reading there, and we're not sure entirely whether it's true or not. Now, some people would do rebiopsy to see. That can also put a lot of strain on an embryo. Another approach is just to transfer. You do see a little bit lower for pregnancy rate and a higher rate of miscarriage, but if born at term, 99% are normal. So that's something you should talk with a clinician about if you have embryos with this. I know a lot of places that won't transfer low-level mosaics. We've had no problem with that. Where their real evolution is actually talking about the high-level mosaics. There seems to be above 50% error, but it's up to 70, 80%. But some people will say these will implant, and it may not be 20%. Some people, I've heard an estimate that high, but it seems more of where I'm hearing is more in the 5% range. But 5% is non-zero. And so definitely talk with your clinician and a geneticist if you happen to have this case. And then full aneuploid, again, usually people talk 1% or less. Again, those numbers will continue to evolve, but if you're more likely to miscarry and potentially scar the uterus and have negative effects for future pregnancy, some would lean away from transferring something that's more likely to negatively affect future fertility for an exceptionally low chance. But again, that's all individualized. Talk to your clinician about that. One other thing that people are sometimes doing is called SNPs. This is parent of origin. I had a couple the other day where there had abnormal embryos throughout, and they were debating, do we do another cycle and just power through it, or do we decide whose sperm or egg were bad that led to the chromosomal abnormalities? And you can make a case each way. First, knowledge is power. Hey, figure things out and then know who it is. At the same time, if these people were saying, you know what, I'll never use donor sperm or donor egg, if you're finding out whose DNA was bad, and you're not going to change what you do for it, that can sometimes lead to just this culture where people point the finger and blame each other, and you don't want to do that. And so I think knowing how you come together as a couple and avoid negative patterns and negative emotions, that's also important to think about too. So talk with a clinician about that. Single versus dual transfer, again, we've talked a bit about that. Compassionate transfer, by the way, some people will transfer embryos that are abnormal. Knowing there's pretty much no chance of them taking, that can be the right thing for some people, but talk with your clinician if that's something you're wanting to explore. Another thing for transfer by the way of oral culture is vaginal incubation. Again, why am I blanking on the name of it? Some people have been into these vaginal incubators for embryos and then transferring those after they've grown in the this incubator that goes in the vagina for 5 days. People say, oh, it's more natural. You know, if you find that natural, go for it. I respect it. But here's the thing. Embryos don't normally grow in the vagina. That is not necessarily natural. People also say, well, it's comparable to normal embryology. I think from what I've seen for the data, I don't want to say that's nonsense, that's rude, but it's kind of nonsense. What I saw was non-inferiority, where if you have a small study, you can't tell a difference, but being unable to tell a difference when you had a really small study just means you needed more people. And I've seen it where you get half the embryos from doing vaginal incubation relative to conventional. You know what? And it doesn't save anything because you still are doing, or at least from what I've seen, you're still doing egg retrieval, still doing transfer, still doing all this other stuff. And if you're getting half the embryos to show for it, I'm very underwhelmed with it. Now, again, some people it's the right thing, want to respect autonomy, but if it were my wife, you know, in those shoes, I would lean away from the vaginal incubation for things. Mini versus full IVF, that's one thing that's actually a little bit misleading. Last time I actually saw a good systematic review, meta-analysis, mini IVF had about 1/3 the take-home baby rate as full IVF. And it's not that you can't make it, you know, economic incentives to do this, and especially if you're doing pills and you're, you know, instead of injectables, and this is a person with a tubal and very young. But the quick version is IVF is a numbers game. And if you're getting 4 eggs, that's a lot less chances than 24 eggs. And so if you're getting 1/6 the yield for half the cost, you're actually paying more per IVF cycle. But some people, again, that is the right fit. I personally find that most people, it's penny wise, pound foolish. It's not giving people the return that they necessarily think it is. And a lot of the best outcomes, by the way, for mini IVF actually involve injectable medication. So it's kind of defeating the purpose. By the way, I've tried for a lot of people with diminished ovarian reserve to use oral medication for IVF. And I found actually a good 50+% of the time the cycle ends up being canceled. So that's also a balance. But again, if you're going to get 2 eggs with injectables and 2 eggs with pills, then I'd lean towards the pills a little bit more just to save the money. But there is a point where mini IVF doesn't give you nearly as much to show for it. You get out what you pay and you get what you pay for. But it can be the right thing for some people. Endometrial receptivity assay, another thing. It's kind of gone by the wayside a lot more. It's, in fact, the group that for IVI Valencia, to my understanding of it, they pretty much said, if you've done this before, forget the results. It's evolved. There was a point we thought it helped 1% per transfer on average, or 1 in 5 people it helped by 5%. The manufacturers were claiming 1 in 3 helped by 5% per transfer. We were seeing it 1 in 5 people had abnormalities in ERA. And ERA, by the way, endometrial receptivity assay, you're doing a blind biopsy of the uterus to see if the window for implantation matches up for where it is ideal. The truth is, I think some of what it picks up relates to endometritis, and if you see, or polyps or other things. And so if you can actually do a hysteroscopy before and figure that out and then treat it, the goal is not a blind biopsy and look at the molecular factors and say, hey, is there something going wrong and do we have to change it and address it? So I think that, you know, a good, thorough uterine evaluation matters. Also for ERA, again, so, you know, you look about 2020, people were saying it was a 1% boost. 2021, large study showed no difference. And then 2022, that was where people were suggesting it might be 1% lower. Bottom line is, you know, if you've gone through a lot of rounds of IVF before or transfers and it didn't take, and then you did ERA and it finally did, it's pretty hard to argue against continuing to use that knowledge and forget it. But I wouldn't start an ERA for most people if it were, again, my spouse, my shoes. That's the metric everyone wants to know. You know, for your understanding of the knowledge, what would you do? I think we're moving the pendulum swinging fairly far away from it. Not that we won't figure out molecular factors, and I think we really need to know more about the uterus. I think that's where some of the greatest opportunities are. But right now, the endometrial receptivity assay is kind of a back burner approach. A lot of the CoQ10, DHEA, testosterone patches, growth hormone, IVIG. I think, again, if you look at the hardest, most of it is really coming down to say, do you have a good embryo? Do you have a good uterus? And a lot of that, people are arguing, really isn't meaningfully changing the odds. IVIG, even there have been national guidelines saying that should only be done in the setting of a randomized controlled trial in a formal setting. I would say, and PrEP, again, for, trying to actually use, purified stem cells and injecting them into the ovary or uterus. I think we're a ways away from the data, but I think the yield for those things, I'm fairly worried it will be far less than we wish or hope. And it's, for me, for IVIG, if it's $10,000 a month for doing it, and it's not, the best study I saw for it showed that it was a 1% lower pregnancy rate, $10,000 for a 1% lower pregnancy rate. It's not, again, you have to respect informed autonomy, but it doesn't have the yield that we hope for. And this is the thing, a lot of things that we'd hope for have dropped by the wayside. The scratch test, now, where you used to sample or scrape away a little bit of the endometrium before a transfer, and that's now showing a 10% lower pregnancy rate. The acupuncture, I remember the best designed study I ever saw for acupuncture actually showed the placebo group did better than the intervention group. In which case everyone should get the placebo, right? But I think ultimately the fact that they've had, for so many of these things which have controversy, if you're going for years and even decades trying to prove it helps, and you can't convincingly come up with studies that everyone accepts saying it's better, it usually means if there is a benefit, it's so small it's hard to prove, and if it adds cost and it doesn't help, that's not at the top of the list. One thing people are always talking about is, do I adjust my exercise? I would say for 3 things for exercise: no abdominal trauma from kickboxing, no extremes of heat, don't boil your ovaries in the summer, I try to encourage people to stay away from advanced yoga, where they're doing contortionist stuff. Now again, push-up, walking, things like that, those probably aren't going to change anything, but true contortionism you do where the ovary can twist upon itself, that's called torsion. And so, you don't want to get in that and potentially lose an ovary, particularly when the ovaries are enlarged. Another thing people are talking about is weight loss. That's probably going, I have a separate video just for that. The quick version is high and low BMI do matter. And now again, a lot of low BMI can be offset through hormones. For higher BMI, that has risk for high blood pressure in pregnancy and diabetes in pregnancy, and you want to be as well as you can. Certainly not to have diabetes, because if your A1C is elevated, that's birth defects, that's miscarriages, that can be increased. At the same time, for weight loss, I do think we also want to say, while we encourage wellness, we don't want to be part of the shame and blame culture, which says, a lot of people say, the reason you don't have kids is because of your weight. What they really mean is, I deserve my kids and you don't. They don't realize they're that tacky or crude when they say it. They absolutely are. So I think we all inherit genetic baggage, and sometimes weight is part of that. And we just have to say, we respect people of every frame, and there's so many people who want to be parents, and the fact that they are a particular dress size or whatever doesn't mean they will be good or bad parents, simply because this is their genetic hand in life. And I think we really need to say that, even as we do also want to acknowledge, hey, the more healthy you can be, that has impact not only just on the pregnancy, but also how the child will do. And you find that if moms have nutritious intake over pregnancy, they actually are more likely to have kids who have fat distributed in different places, which has implications for how they go through life. So I think these things can matter, and it's a balance for how you phrase it, but you always want to treat everyone with the dignity and respect as much as possible. Another thing I get on travel, everyone's asking me about flights. First, you have to talk to any airline about things. My general rule of thumb is, I prefer to see where people are for having recovered, from a retrieval, from transfer, everything like that. We kind of don't want to have a miscarriage, in the middle of nowhere where you can't get medical help, and you certainly don't want to be delivering on a plane. But that gets into individual risks, but it certainly stay mobile. TED hose for any longer flights in particular, very long flights. If you are flying to India, you may want to also get some Lovenox for the flight if you're pregnant or immediately post-retrieval. Honestly, you probably want to get out of that window before you do a very, very long flight. But again, there's a lot. You talk with your clinician on that particular one. This is general medical information. I want to be as accurate as I possibly can. But subscribe, forward this to friends who need more insight on IVF. And best of luck. I hope you have the family of your dreams.